Yeah, I need to do a test. I'm getting your speaker is not working. Are you able to hear me?
Hi, Tim. It sounds like you're a little bit choppy.
Okay, I just got your speaker is not working. Can you hear me now?
Yeah, it sounds much better.
Okay. Okay, we are live. Welcome everyone to the November 6th Addiction Toxicology Case Conference. I am Tim Wiegand. This is a joint initiative made possible in part by a grant from SAMHSA. The views expressed in this written conference materials and publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. This is made possible by support and collaboration with the American College of Medical Toxicology, the American Society of Addiction Medicine, and the Opioid Response Network. This material is accredited for one credit, category 1 credit for AMA, and you will complete a survey at the end to receive that. I'm Tim Wiegand, the Director of Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center. My co-moderator is Dr. Gloria Bishevitz, Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Rochester Medical Center. We have a distinguished group of panelists joining us today. First is Dr. Derek Eisner, Medical Officer, Division of Clinical Development, Biomedical Advanced Research and Development Authority at the Office of the Assistant Secretary for Preparedness and Response, U.S. Department of Health and Human Services. Dr. Lewis Nelson is a professor and chair of emergency medicine at Rutgers, New Jersey Medical School. Dr. Natalie Newman is the clinical instructor in the Department of Emergency Medicine, Yale School of Medicine, Yale University. And the guest expert, Dr. Mark Schwager, is associate professor at in the Department of Psychiatry at the University of Rochester Medical Center, Rochester, New York. We have no conflicts of interest to disclose, and we'll jump in with case 1, titled "A Ketamine Clinic and Depression: Questions from a Patient with Opioid Use Disorder." Case 1 involves a 28-year-old female with substance use disorder, which includes a history of heroin and fentanyl, cocaine, cannabis, prescription benzodiazepines, and stimulant, both amphetamines and methylphenidate use. She's currently receiving buprenorphine and naloxone in an outpatient addiction treatment program. She's interested in attending a ketamine clinic for depression. She states she had undergone a very positive ayahuasca experience a few years prior, traveling to Brazil to do so, but it wore off, and she's hoping her response to ketamine will be similar but more sustained. Further information, her medications include buprenorphine naloxone, 8 and 2 milligrams sublingual twice daily. She also takes clonidine, 0.1 milligrams twice a day as needed for anxiety, escitalopram, 20 milligrams a day, and topiramate, 50 milligrams twice a day, which is off-label use for cocaine craving. There have been numerous prior prescriptions for anxiety medications, including recently stopping gabapentin, bupropion, which increased her anxiety and didn't help her mood. The medication use often was interrupted as she missed follow-up to mental health, provider counselor appointments, and prescriber appointments, just in general. Her buprenorphine was regularly continued, and her urine screen has showed that she's taking it over the last 1.5 to 2 years. She has heavy cannabis use that's persisted, and she states it helps her anxiety and PTSD. Last stimulant use was 9 months prior and was cocaine, and she's had intermittent benzodiazepine use throughout the time period. Her formal diagnoses include depression, anxiety, and at one point PTSD, borderline personality disorder, and bipolar just in general, and it was unclear where that really had come from. Patient had begun using cannabis in her teens and has continuously used cannabis almost on a daily basis. She also smokes about a pack a day of cigarettes, no alcohol use, and the stimulants for ADHD started at about 12 years old, and she was misusing them by age 15, on and off for about 7 to 8 years, progressing to cocaine use. Prescription opioid use developed in the early 20s and progressed to heroin and fentanyl, and then she started buprenorphine for the last 2 years, and a little bit intermittently prior to that before really stabilizing with regard to her opioid use, with a few months, some interruptions, but generally continued to take the buprenorphine. For about 9 months after the ayahuasca experience, she was not on any psychiatric meds and doing well. And this was about 3.5 years prior. And this is all her self-report. And again, frequent changes in providers, PCP or lack thereof, frequent changes to mental health or missed DC appointments. And the addiction providers often not prescribing the mental health medications to avoid disruption or discontinuation. So my questions to the panel are, what is a ketamine clinic? And then discuss the emergence of these programs and the use of ketamine for depression. And why don't we start with Dr. Swager? What is your experience with ketamine clinics, and what is the use for mood disorders?
Thank you. So what a ketamine clinic is really depends on which ketamine clinic you're in. Most frequently, ketamine is used at relatively lower doses, 0.2 to 0.5 milligrams per kilogram IV. And there is mounting support for using it in this way. It does seem to provide rapid relief from major depressive episodes. Now, there are some concerns I have about this. First of all, the relapse rate is relatively high after 2 or 3 weeks. And these lower doses, they may be effective for depression in the short run, but they do tend to create some what you might call side effects. Emergence phenomena is what they're labeled. And those can be somewhat disorienting and distressing for patients who are not prepared for them. And so this is the use of ketamine in most of the clinics that I'm aware of, especially in Rochester, New York. But there are ketamine clinics who do higher dose ketamine assisted psychotherapy that involves a couple or several sessions of preparatory psychotherapy, just to build a relationship and discuss what the ketamine experience is going to be like, and then a dosing session, which is much higher dose, sub-anesthetic dose of around 1 to 2 milligrams per kilogram IV or IM. And that's a different scenario, because those therapies, ketamine-assisted psychotherapy, is more along the lines of the psychedelic psychotherapy that we're hearing so much about, using psilocybin or MDMA. And they involve a lot of support and post-dosing integration. So I'm not sure where to go after that there. Did you want me to go on to the next, what conditions is ketamine being used to treat?
Sure, this is Tim. I just switched the audio. I think it was coming through a little bit garbled. Hopefully this is better. That was great, better. Mark. Thank you. Maybe I'd like to get a little bit of experience from some of the other panelists as well. Dr. Newman, what's your experience? You originally were in Denver and moved to Yale. Have you seen the ketamine clinics being used? What's your interaction with them?
There's actually one 10 minutes from my house. I did a similar Google search to see if there were any nearby, but I actually haven't seen many people refer to them, and it wasn't something that I saw much of in Denver. My experience really has been more in using ketamine in the emergency department. It sort of pertains to the cases that you have coming up, and also having seen it being used for pediatric sedation. I've heard people in addiction medicine and psychiatrists discuss it as a potential therapy for depression and addiction medicine, but I myself have not been involved in any of that treatment. Thank you.
This really today was on the background last month was we were discussing agitated delirium, excited delirium, and ketamine came up in use for treatment. And in follow-up, we wanted to do a deeper dive because ketamine really, addiction providers and medical toxicologists, clinical providers may come into ketamine, encounter it in a variety of settings. It's really an interesting medication pharmacologically. So Dr. Bashevitz, maybe you can discuss your experience with ketamine. Have you seen it used? Have your patients asked you about it?
So no, most of the time my patients don't ask about it. So I haven't met anyone who's actually been to these ketamine clinics, unfortunately. It has some interesting promise, especially the S-ketamine, which is an enantiomer of ketamine and is actually approved for treatment of depression.
Thank you. Dr. Nelson, did you have anything you wanted to add? Have you seen the ketamine clinic?
Yeah, two quick things. One is, at my current job, we don't do this, but at my prior job, we actually were studying the use of ketamine in the ED for people with depression as sort of a rapidly acting antidepressant. I think that it didn't pan out to be as good as everybody expected, but it did seem to have some benefit to a small number of people. And I don't know that we've gotten further along to determine which patients are most likely to benefit or not. I left the institution, but it was very interesting. It was something people really were very excited about. The other question, this is more of a question, I guess, is in this woman's case, were we treating her depression with ketamine? It sounds like she had tried the ayahuasca and other things to treat her substance use. Was that also used to treat her depression? Or were we linking the two together and saying we're just treating, whatever it is that we can hope to accomplish with the psychoactive medication? Because there is obviously a long history of use of these sort of psychoactive drugs to treat substance use, not necessarily depression. Again, unless you're linking the two together.
Well, I think that's a great question and something we discussed as well. She tended to have an interest in psychedelics and travel, was an interesting individual, did a lot of research online. And initially, it seemed when she did the Huska trip, the experience, her substance use, and this is again self-report, diminished and her mood improved. So it appeared that at that point things were linked. Whether she truly understood, what she was looking for, and was dissecting one or the other, I'm not sure. That's an interesting thought. In this, it seems she's focusing on her mood. Although mood is tied in with substance use certainly as well. And I think I wasn't clear to me what the ketamine clinic was offering. When I look at the services online, that some of the clinics really have focused support with staff that are trained in cognitive behavioral therapy and other techniques. Others have really just a moonlighting nurse practitioner that is present to give the infusion and a series of infusions, and that's essentially it. I know, Dr. Swager, we've talked a little bit about this, and you had visited some of the clinics. Maybe you can comment a little bit about more on the variability of supports and the differences in the research protocols versus really what the clinic experience is.
Yeah, there's really high variability in what conditions clinics are purporting to treat. And they're certainly advertising for a lot of different conditions. But the research suggests that ketamine is efficacious for some folks for depression in roughly a dose-response relationship. And also for substance use disorder. But the interesting thing about it to me is that and we'll get into this with mechanism of action, there's some evidence to suggest that higher doses can occasion peak experiences that really result in a real reshuffling of cognitive set. And so basically what this means for this patient is that 9-month self-reported period of doing well is pretty important, because it's the ayahuasca experience that she indicates is much more akin to high dose ketamine assisted psychotherapy than it is to lower dose ketamine therapy. And with those higher doses, as I would suggest with lower doses, but especially at the higher doses, a great deal of support and know-how is necessary in helping patients work through that. And I think what's happening in some of these clinics is that patients are being kicked into, for lack of a better word, psychedelic territory without being prepared for it. And so it creates an interesting situation where maybe you're following ketamine with a benzo to calm them down or try to reorient them. Or if there's adequate support, maybe people are going in and beginning to work on issues that have led to both substance use disorder and depression.
That's great. That's very interesting. One of the areas that I was particularly interested in, I had a question about use for OCD, obsessive compulsive disorder. And once you start looking at where ketamine is used, this idea, in effective cases, it really seems that there is some reshuffling or resetting, as you refer to, and it's intriguing on the dose. The dose makes the poison, the dose makes the response, the dose makes the antidote as well. So whether the clinic is using the right dose and the set and their support is going to be critical potentially, which leads me to the next question in terms of mechanism of action. Dr. Eisner, you want to comment on the mechanism of action for ketamine and
Sure, Tim. Thanks. So those of us that are toxicologists and kind of pharmacy-based, we would sometimes we've referred to agents like ketamine as a dirty drug in that it has many different receptor effects, NMDA primarily, but also opioid receptors, noradrenergic effects through inhibition of uptake transporters, serotonin effects, even cholinergic muscarinic effects. But the primary receptor action is as an antagonist at the NMDA receptor, and the concept is that this kind of causes a disruption of thalamocortical filtering to the cortex. My understanding of the current mechanism of action, particularly if we focus on the evidence that really looks at looking at these treatment-resistant major depression disorders, is that we see in a number of studies, we see kind of a decrease in basal glutamate levels, particularly in areas of the brain like the prefrontal cortex. And the interesting thing about ketamine and agents like ketamine is it has the ability to, as others have mentioned, to rapidly kind of boost those glutamate levels so that, some of our frustration with our historical antidepressants is that many of them, it takes time to actually have reach therapeutic levels and have a therapeutic effect. Whereas with these infusions with ketamine, we get, the studies have shown a very rapid clinical benefit within a very short period of time, less than 24 hours. But also, as others have mentioned, that there appears to be some neuromodulation where we see an upregulation of NMDA receptors and also type 1 dopamine receptors. And so in those particular areas like the prefrontal cortex, we see an increase in basal glutamate levels. And so I believe, that's my understanding of the current, one of the current theories in terms of its anti-depression effects.
Thank you. And for all the audience, I want to remind you, we have summary sheets that will be available after the presentation, and that the presentation is recorded and slides are available. Dr. Nelson, do you have anything to add to that summary on ketamine pharmacology?
I think it was pretty complete, actually. I agree, it's a very complicated drug.
Yeah, I've always thought it is a dampening down the excitatory activity, and that certainly is an oversimplification. In the treatments of withdrawal or excited states, you can approach it from enhancing inhibitory tones or GABAergic agents, and ketamine approaches it from the opposite direction through dampening down the excitatory tone. And for depression, there's some unique mechanisms involving the glutamate receptors, as well as many other different areas that Dr. Eisner mentioned. And Dr. Bashevitz already commented on S-ketamine. That's an enantiomer, as S-citalopram is to citalopram. S-ketamine is to ketamine, so available as a nasal spray. Dr. Bashevitz, are there any chat questions that have come through that are pertinent at this time?
Yes, there is one that I'd like to answer, and the question says, are we able to treat depression only by psychotherapy and avoid drugs entirely? Certainly, many cases of depression can be treated by psychotherapy alone, but when we're talking about using medications like ketamine to assist treatment of depression, we're often talking about something that's called treatment-resistant depression. And often, if you take a history of other drugs that have been tried, that certainly other antidepressants had already been tried with the person.
Good, thank you. I remind the audience you can chat in some questions and we'll selectively answer them. Moving on with the case, the patient reported she had taken a trip to Brazil for an ayahuasca experience about 3.5 years prior. Kind of summarize that. So my question now to the group is, what is an ayahuasca experience and what is the pharmacology of the ayahuasca? We can start with Dr. Swager again.
Ayahuasca is considered a classical psychedelic, so it's tryptamine. It's basically DMT mixed with plants that have alkaloids with MAOI activity, because DMT is not active when ingested orally. It is active. Many people smoke DMT. The experience is often done in groups with a shaman or a leader of some sort. And this sets up a trusting atmosphere where people take ayahuasca and have a psychedelic experience, after which, and this lasts a number of hours, a day, basically, and after which there's a period of, if all things go well, a period of integrating what people have learned from the experience. A lot of these I'll call them good ayahuasca ceremonies are going on all over the world and have for a long time. Unfortunately, some people have sprung up that are scams and attempts to profit from the popularity of the drug.
Certainly, I've seen, in reference to drug tourism, is individuals really just seeking the experience without really, I think, fully understand what it entails. And there is it fascinates me in terms of how it was determined to add the MAOIs to the plants containing DMT, the other tryptamines. It's not just simply dimethyltryptamine. I believe it's harmine and harmaline in order to negate the gut MAOI, monoamine oxidase inhibitors, for facilitating the absorption and the experience. How that occurred is very interesting and fascinating. And there is toxicity in terms of risk with this experience as well. There's publications of serotonin syndrome and adverse psychiatric effects, but in general, the tryptamines are one of the safer classes of psychedelics when used appropriately, and again, in the right dose and depending on the set and setting. Does anyone else want to comment on the ayahuasca experience or the pharmacology?
Tim, it's
Dr.
Lewis.
Newman?
The
Go
only
ahead, Lewis.
thing I would add is that if you go on the internet and Reddit and some of these other drug use sites, you'll read about sort of the homegrown version of ayahuasca. And there are ayahuasca parties in the United States that don't involve, Banyapsteris, the vine and the plant and this other stuff brought in from South America. They can actually use DMT that is either synthetic or derived from other plants. And, DMT is relatively commonly available. And MAO inhibitors, like phenelzine or drugs that we've used therapeutically. So, or as kind of suggested, you can insufflate it and bypass the GI tract, and then the DMT is active.
A couple of years ago, we had some cases involving internet-ordered ayahuasca and accidental overdose. And there was an analog of psilocin that was available. It was acetylpsilocin, which is one of the tryptamines in essentially shrooms, psilocybin and psilocin. And I believe the acetylation kind of bypassed the Controlled Substance Act. So we saw some of that, although not exactly the ayahuasca experience, because that involved more tryptamines and ceremony and preparation. We did see at least a cluster a few years ago in the ED when some of the experiences went awry. So let's continue. The tryptamines, dimethyltryptamine, psilocybin, psilocin have been considered for a variety of medical conditions, including mental health, addiction, and medical conditions. Where has research demonstrated some effectiveness? This is pertinent. I believe it was Oregon or Washington. One of the states have legalized or decriminalized small amounts of the tryptamines. Someone can maybe elaborate or correct me if I'm wrong, but the tryptamines are in some areas. In Denver, I believe, even looked at passing a city statute regarding decriminalization of the tryptamines. But where has research demonstrated effectiveness? Maybe Dr. Swager, you can comment a little bit on this.
Yeah, and I think the most has been, at least recently, has been on psilocybin, and certainly Griffith's group at Johns Hopkins has done some work on anxiety, death, or illness-related anxiety. There is some evidence that psilocybin's useful for depression, and these are clinical trials, and they're recent clinical trials. So in addition, there has been some research on psilocybin and substance use, and LSD and substance use, and a lot of the older research is not half bad. If you read it, it has kind of gotten a bad rap because of the 60s and Timothy Leary and such, but they're rediscovering its use in substance use disorders and a number of other conditions.
I think that there was a House episode in which they used psilocybin to treat cluster headaches as well. So the variety of it was serotonergic, and that's based on not too far off from reality in terms of clinical studies looking at that. I mentioned a little bit about the risk, the toxicity associated with the tryptamines. They are serotonergic, and I've seen cases of serotonin syndrome. And most of the emergency department visits from mushrooms, the psilocybin, psilocin, are going to be related to trauma, accidental trauma, or toxic psychosis from my perspective. Dr. Newman, do you have any other thoughts? Have you seen tryptamine-related ED visits?
No, I haven't actually. And I think I agree with you that sort of the serotonergic toxicity would be the most concerning. I actually, kind of going back a slide or two, I think we were sort of touching on the mechanism of action for ketamine for depression. I think this is going back a couple slides. The only other thing I was going to add, I was trying to speak up and I sort of missed the moment, but there's also, I think, because I think there's a lot of psychiatrists on the call, there's some thought that ketamine interacts with modulation of the default mode network, which I know is one of the theories of how depression evolves. And I think there's also some studies looking at opioid antagonists and how opioid modulation will change the efficacy of ketamine in treating depression. So I just wanted to add that onto the prior discussion. I think there's I think the mechanism of action for ketamine treating depression is not entirely clear at this point. There's also, I think it's sort of interesting, the interaction of ketamine with sigma receptors is also something that's starting to be looked at. And I believe sigma receptor agonism is also being looked at with different medications for the treatment of depression. So I think TBD in terms of how ketamine itself works for depression. And then going ahead to, or moving back to the ayahuasca discussion, I tried to do a little digging in terms of how ayahuasca would potentially treat depression. And I didn't find, kind of I think we've sort of been dancing around this, to the point of, is there much literature about psychedelics and treatment of depression? I couldn't find much that was definitive. Sort of the hypotheses of addiction treatment and depressive treatment were that there's a change in dopamine concentrations that changes synaptic plasticity associated with the development and maintenance of addiction. There were changes to dopamine concentrations in the mesolimbic pathway. And then there was some thought that because as part of this ayahuasca experience, you start with your nausea, vomiting, and have some more mild hallucinations and kind of vivid imagery during the second part of your ayahuasca experience. My understanding is that you have sort of spirit guides, and there seems to be more of not didactic isn't the term, but there seems to be more of a discussion between the person who has taken the drug and kind of the spirit world. And the idea is that in this discussion with the spirit world, maybe people they're able to deal with traumas in the past, or able to process their addiction or their mental health disorders in a way that was previously foreign to them. So I just thought this does not have as much to do with toxicity, but I thought they were interesting proposed mechanisms of action for these two drugs. And then I guess, sorry, I keep going on, but I guess my final comment, and it's more of a question for the people on the call, is I sometimes wonder with, discussion of ayahuasca trips and they're being used to treat depression and addiction. There's almost this, because they've been used for hundreds, if not thousands of years, there always seems to be the implication that because human beings have used them before, they're necessarily safe, or like they have been used historically for treatment of addiction or to benefit human beings. And I don't know if, it almost seems like these herbs are being taken out of context. And anyway, it's just more of a question for the panel. I think there seems to be a legitimacy associated with using these herbs that maybe they have not earned, at least in a Western context.
I think go ahead, Boris.
No, I would agree with that. I think all of these ayahuasca, even ibogaine, a few of the others that are used, they've always been used more as sort of a mechanism for shamans to communicate with the gods, used on a very limited basis, not therapeutically. And I think we've sort of converted them into a therapeutic modality. I mean, some of these things are maybe, depending on your perspective, proving to be helpful in psychotherapy. And there's been a lot of folks, as has been commented on in the chat, looking at psilocybin and looking at MDMA and others to help to enhance the psychotherapeutic relationship. We're starting out looking at that again. I mean, there was some work done in the 70s, and I think we're really back at knocking on the door of this again. But I think we're medicinalizing it back in the more of the tribal use was for other purposes. I don't think it was to treat depression. I think it was shamanistic.
Yeah, it's interesting. I find that many of the individuals that have expressed interest have a history of prior hallucinogen use, and some of them would meet criteria for hallucinogen use disorder, certainly. So, their interests may be more recreational rather than therapeutic. And, that's in my review for this presentation, there seemed to be a wide variation in quality and controls, and really what has been offered in much of what is available in terms of the clinic, and just kind of a ketamine clinic, getting back to that, is people charging ahead with kind of opportunism. At the same time, there seem to be real mechanisms when you find the right dose, the right individual, the right study setting, and the right context for these drugs. And, there's a reemergence in medicine, but as has happened with a lot of things, the commercialism seems to be charging ahead of really the evidence base and the appropriate use and research. Dr. Bashevitz, do you have any chat questions you wanted to address?
Well, one of them is, can the panel please comment on the new JAMA psych study that just came out about using psilocybin for depression? Has anyone looked at that?
Dr. Swagert, would you like to comment?
I just saw that existed, and I have not looked at it. It wouldn't surprise me. I guess I'd like to kind of bring together this the idea of ritual shamanistic use in modern Western medicine, especially with psilocybin and potentially with ketamine. It looks like these, and it's right here on the slide too. Let me go through this slide a little bit, and I'll get there. So this is from Griffith's lab at Johns Hopkins, and is typical of the sort of randomized controlled trials that are going on. And the response that people are giving on measures of quality of life and meaning and death acceptance and optimism, and the effect sizes for these are huge. And this is not just this one study. It's numerous well-controlled studies now of psilocybin across different areas. And it seems as though, in addition to leading to an increase in openness that is sustained over the next year, and for those of you who don't know, openness is a personality trait that typically takes decades to change. But these psilocybin sessions with proper support and proper dosing and proper integration, among people who have a mystical experience during these sessions, they're reporting results we don't see in psychiatry. And so in terms of effect sizes and long-term follow-up, and so it may well be that the mechanism, we've talked about pharmacological mechanisms, the psychological or phenomenological mechanism may be a mystical experience. And what I mean by that is an experience where time and space is distorted. There's a feeling of connection, that all is one, and that there is meaning to the universe, and it's largely a non-cognitive domain. And so when we talk about the default mode network being impacted by these medicines, the psychological phenomenon is a mystical experience, and those seem to be a mechanism that may be necessary for the best outcomes in these cases.
Now, that was very well explained. I think that reminds me of some of the review of the initial experiences involving magic mushrooms that generated so much interest in the 60s, the mystical experiences, the religious experiences that were reported after use, and then led Timothy Leary down the rabbit hole later on. But there certainly was some sort of experience happening with individuals in these early studies. And as you summarized, ketamine, I found an interesting quote from 2014 from Dr. Thomas Inzel, the former director of the National Institute of Mental Health. He said, recent data suggests ketamine given intravenously might be the most important breakthrough in antidepressant treatment in decades. And this quote was used in many of the clinics, but without a lot of context. Also stated there are still a number of questions to resolve about the best dose, the mechanism, long-term efficacy, and safety. And this is just a screenshot of, we have a upstate ketamine clinic in Rochester that two of them actually, and then a couple of others in the area, as many of people on the call. Interestingly, this patient had been originally planning on repeating her experience and going to Brazil, but travel plans were derailed, not just from COVID-19, but because of finances, which then precipitated the ketamine interest. And she was going to pursue ketamine until she found the cost was approximately $500 per treatment. And there was a required series of treatments that they accepted cash only for at this clinic. And looking online, it seems that that's pretty common. There's a series of treatments involved in ketamine when one is attending a clinic, and that often insurance is, I've not seen one where insurance is covering the stay. So I don't know if this is in line with what your experience, Mark, is, or at least what you've looked into.
Yes, very consistent. Now, some of the clinics on the West Coast that are doing the full psychedelic dose ketamine with support and follow-up will charge about $400 or $500 for a single treatment, and then many times the psychotherapy before and after is covered by insurance, so that can be helpful.
Yeah, that's a great qualification. And there are a number of studies going on through different groups. You mentioned the Griffith Lab, but the MAPS, which is Multidisciplinary Association for Psychedelic Studies, that seems to be increasingly involved in funding research in this area. We're looking at the ayahuasca retreats in Brazil or Peru. There's a wide variety of types, and some seem to be more slanted towards just simply travel experiences, and others more philosophical, religious, shamanistic, and typically they involve a several-day experience and fasting, and prices are all over the map depending on what one looks at. I want to move a little bit ahead. I just wanted to summarize. We could talk about psychedelic use in medicine for mood, depression, for substance use. We didn't talk about ibogaine. That comes up frequently when one is considering heroin addiction or opioid use disorder. There are ibogaine clinics, not in the United States, but in Tijuana, Mexico, that we've had patients travel to from Rochester in the past. And I know that Dr. Nelson has been involved in some case presentations regarding toxicity from ibogaine, cardiotoxicity. We talked about ayahuasca, ketamine, and S-ketamine, tryptamines. We didn't talk about MDMA, which is methylene deoxymethamphetamine, or traditionally known as ecstasy, which had some initial use for the treatment of PTSD and guided psychotherapy, and very quickly was turned into a party drug. And then LSD initially for alcohol use disorder, currently being reconsidered. What we didn't talk about are dosing regimens, things like microdosing, which in particular with tryptamine seem to be, we talk about higher doses in terms of resetting something in mystical experience, but I also saw reference to microdosing over prolonged periods, potentially also being used as a treatment for depression. And does anybody want to comment on microdosing and the tryptamines in particular?
The anecdotal evidence is very positive, but I think that the better studies of microdosing are just getting started.
Oh, very good. And this is not the microdosing we're talking about with buprenorphine, but low dose tryptamine taken over time. So
Yes.
Just a slide from the media page, 2012, LSD and alcoholism revisiting use initially started in the 60s. And again, some mention that there may be something here in the right context. So let's move on to case 2. This is another case that features a different aspect of ketamine. As a ketamine is an adjunct to sedation after a mixed opioid benzodiazepine overdose with acute lung injury. 32-year-old female with alprazolam use disorder and dependence on benzodiazepines is found unresponsive after insufflating some Percocets. She has a transient hemodynamic response to intranasal naloxone, but she does not wake up. In order to appropriately ventilate and control agitation, requires 250 micrograms per hour of fentanyl, 8 milligrams per hour of midazolam, and 2 milligrams per kilogram per minute of ketamine. Also, shortly after admission, the ICU team is contacted by the patient's mother, who says she's been informed that her daughter-in-law had been in contact with a person who had been diagnosed with COVID-19. Contact precautions and testing ensued. And so my question to the panelists is, how is ketamine used in the ICU? For what conditions, and what is the mechanism of action here? And are there particular considerations on the use of ketamine in the ICU, drug interactions and side effects? And Dr. Eisner, you can start us out.
Thanks, Tim. So, most of my experience in the emergency department is using ketamine for procedural sedation, particularly in kids. Also very useful in cases of RSI use. My concerns in terms of when you would want to have caution would be, theoretically in situations where you might be dealing with adrenergic excess. The other problem is due to a significant amount of overlap with patients with psychological diseases or diagnoses and substance use disorders, you want to be very careful if you have a patient with subclinical or schizophreniform type disorder, that use of ketamine, particularly in subanesthetic doses, could precipitate acute psychoses and actually increase agitation. But I mean, it's very useful. I think that when we approach our ICU patients, we need to approach them individually. There's not a one size fits all for sedation. Is there a need for analgesia in addition to sedation? Over. Anything else specific?
No, I think that we had Dr. Ryan Magnuson on a few months ago, who is an intensivist at the U of R, commenting on changes to sedation protocols related to COVID. In particular, as the patients are hospitalized for acute lung injury, the need to use extremely high doses of sedatives, opioids, and other sedation to adequately ventilate and oxygenate the individual is really important. There's also less contact, although I think that's improved. So less sedation holiday, less interruption, higher doses, and which led to use of more combinations of sedatives as well as more iatrogenic dependence. And I've seen ketamine added more frequently to the mix. In the cases we're consulted on in toxicology or toxicology and addiction, there's often a high degree of opioid dependence, or sometimes sedative dependence. And, so in this patient, she did have acute lung injury, combination aspiration, as well as pulmonary edema, I think, from the naloxone reversal. She was quite hypercapnic when she was arrived, meaning CO2 was very high. So she required high doses of sedation. The ketamine was very useful adjunctively in order to keep her calm and keep her ventilated. Dr. Nelson, do you have anything you want to add to the use in the ICU, ED?
I think it's got real potential. I mean, one of the advantages of it is that it's both a pain medicine and a sedating medicine, which is something that could be used to replace two different medications, both of which, particularly fentanyl, when used for a long period of time, has some pharmacological properties that make it hard to wean, right? Because it's very fat soluble and it lingers for a long period of time. Ketamine doesn't seem to do that as much. People do tend to wake up a little bit more quickly, which makes it easy, not as quickly perhaps as after using propofol, but it does have some benefits. The drug interactions are relatively minor overall. It's got a unique pharmacological profile, has been commented on, but most of it probably really is related to the NMDA receptor antagonism, which does carry with it some potential neuroprotective effects. And one of the reasons it's used for some neurologic disorders, I mean, other than the psychiatric disorders we've talked about, but people have talked about its use for alcohol withdrawal, for example, to kind of turn off the excitatory neurotransmitters glutamate in the brain by binding to that receptor and inhibiting it. So there are some potential benefits. I think it's relatively poorly studied up till now, though. And I think one of the concerns has been suggested is some of the psychological adverse effects, particularly if you underdose it, right? And people are allowed to sort of become sort of a little light on their ketamine sedation. And often it's used with a sedative like propofol for that reason, because the psychological effects of being in that mid-range ketamine, as opposed to deeply sedated or at the pain, very low pain dose that we'll use, sometimes can lead to, short or maybe even long-term adverse outcomes.
Yeah, those are great comments. The first time clinically that I was exposed to ketamine use was in burn care in a pediatric patient, and it was quite painful procedure that the child was undergoing with relative ease. And the best word I think that comes to mind is dissociative and analgesic. I think the child did not realize that he was getting care and seemed quite calm. The emergence phenomena is less common in pediatrics. The comment about adrenergic risk, adding ketamine to someone that has a hyperadrenergic state, from my review, has been overstated somewhat. It's used in the treatment of agitated delirium to fairly good extent when appropriately used. That was an entire webinar last month where we talked about agitation and the degree of agitation and use of sedation, and as a part of a continuum in working with patients that have agitation. And certainly there's appropriate versus inappropriate use of ketamine in that context. And in fact, the ACMT has put out position statements on appropriate use of ketamine in under medical direction and for particular patients. But I think the use in adrenergic patients and risk is overstated. I don't know if you want to comment a little bit about that, Louis.
I fully agree. I think, remember, you got to separate the pharmacological effects and sort of the, philosophical and other effects that go along with how it's used, not the drug itself. I think the drug used for agitated patients is fully pharmacologically effective, and it does a great job. I mean, if the hyperadrenergic state is not at all a contraindication, even though ketamine in and of itself causes you to develop some hypertension and tachycardia. When used in somebody who's hypertensive and tachycardic, it usually sedates them enough to actually lower their heart rate and blood pressure. So it's not really an issue. You do then have to weigh the benefits and the risk of the agitated patient and harming themselves and others to the risk of the drug. But the risk of the drug is actually fairly small. In and of itself, ketamine sometimes as a sedative produces some cardiorespiratory depression, right? And you'll sometimes see people actually wind up over sedate and they actually drop their blood pressure a little bit too far, which isn't what you'd expect in somebody who's getting ketamine fresh. In other words, somebody who you're giving it to for a procedure or something where they almost always have a rise in their blood pressure and pulse. Somebody who's coming from the other direction, already very stressed, sometimes develops an exaggerated depression of their vital signs. But used properly, I think, again, in the right context, pharmacologically, I think it's a terrific drug.
Yeah, very good. The high doses I've seen hypersalivation as well, I think, and that's used at the extreme doses approaching 5 milligrams per kilogram when you have the most severe excitation, but not occurring at the lower doses necessarily. This patient had a prolonged course, which included use of microinduction, not involving tryptamines, but involving buprenorphine. The microinduction protocol was initiated while the fentanyl was in place and entails a dose of 150 micrograms sublingually or buccally every 6 hours for 4 doses, with slow titration up to full buprenorphine dose of 16 to 24 milligrams. The team used phenobarbital to facilitate the sedative wean, which took longer than anticipated, and the ketamine was titrated down during the first 2 days. Dr. Nelson talked a little bit about using ketamine for alcohol withdrawal syndrome, covered the microinduction process with buprenorphine briefly. And does anyone have any other comments on sedation use in general during COVID-19 or intubation in patients, intubated patients in particular? Or in any of the questions, comments here. Dr. Bishevitz, do you want to have anything additional or from the chat?
There are some general questions about PTSD. Do any of these agents work with PTSD? Maybe someone would like to comment on that.
MDMA.
I've seen,
oh, go
that's
ahead.
what I was going to, Dr. Sauger. Yep, that's exactly what I was going to state. I've seen.
Oh yeah, there have been quite a few trials of MDMA. I think there a large number of people, thousands of people, have been dosed with MDMA for post-traumatic stress disorder, and it's sort of been put on the fast track by the FDA. And in fact, Dr. Bishevitz and I have been talking about potentially working on an MDMA for post-traumatic stress disorder and substance use study. So it seems to be pretty effective, and we're just awaiting more data.
Dr. Newman, any other comments or thoughts?
No, I mean, with respect to the ketamine for alcohol withdrawal, my understanding is that it's, I think, used for benzo-resistant alcohol withdrawal, and I feel like so many people have moved towards using barbiturates that it's not something that I've actually seen in practice with respect to the one question on this slide up top. And for PTSD, I personally don't have anything to add there, I'm afraid.
Thank you. We have real limited experience, at least in my institution, for alcohol withdrawal and ketamine. We're considering it in certain situations, in particular, to limit benzodiazepines. We tend to use phenobarbital, but I do have colleagues that have studied ketamine use in the management of severe alcohol withdrawal and doses of 0.1 to 0.3 milligrams per kilogram. Dr. Paisan and colleagues down in Pittsburgh had found in a group of patients less use of GABAergic agents, shorter ICU stay, lower likelihood of intubation, and a trend towards shorter hospitalization. I believe this was in about 60 patients, if I understand right. So there's some basic studies looking at ketamine adjunctively for alcohol withdrawal as a benzodiazepine-sparing medication, and to perhaps get better control more rapidly. This patient had a prolonged ICU stay, primarily related to the acute lung injury and challenges with sedation wean. After the buprenorphine initiation and her lungs improved, she tolerated a sedation wean. She had paroxysms of delirium in the hospital after extubation, required several weeks to stabilize, medically undergoing physical therapy, occupational therapy, receiving nutrition. She had addition of atypical antipsychotics in the ICU that were titrated up to fairly high doses to stabilize her sleep-wake cycle and some delirium. And valproic acid was added as an adjunctive agent for sedation. And the alprazolam was discontinued, as was gabapentin, with contact to our outpatient prescriber. Case 3, we're coming up to the end of the hour, although I'm just going to briefly cover this because we're not going to go over the case. It just represents a different use of ketamine in a highly opioid-dependent patient, a 25-year-old African-American male with sickle cell disease, presents to the ED with acute pain crisis. He's opiate-dependent, has an opiate use disorder, and is prescribed large doses of hydromorphone by a hematologist, and he's struggling with overtaking them. He's hospitalized during COVID-19. And in addition to high doses of parenteral hydromorphone, he's placed on a ketamine infusion, which enhances his pain control quite dramatically. This is the only slide, and then I have one final slide. We've commented a little bit about the role of ketamine for pain control and analgesia, and I've seen its reference to resetting tolerance in some of the patients that have very high opioid doses and burdens, that small doses of ketamine adjunctively can really kind of reset the degree of dependence and tolerance and allow for better control of pain adjunctively. Does ketamine use with highly opioid-dependent patients modify the degree of tolerance and dependence in opioid dose requirements? Dr. Newman, do you want to comment on that? Maybe briefly.
I've not in my experience, to be perfectly honest, and not mechanistically, it doesn't make much sense. We talked briefly about the interaction of ketamine with opioid receptors, but it seems that does not seem to be the mechanism of analgesia. That seems to be more what people discuss with NMDA receptor antagonism. So I have not had to change ketamine dosing for patients who are on opioids or opioid dependent myself.
Right. I've seen reference to the NMDA receptor antagonism and potentially other opioid receptor sigma modulating the tolerance effect after repeated opioid use. And one of the reasons potentially that methadone as the racemic mixture works better over time, and there's less tolerance compared to just single enantiomers. So this patient improves over several days in the ICU, undergoes a buprenorphine microinduction. After review, it appeared many of his pain crises were precipitated by opioid withdrawal. He also admits to insufflation of his prescription opioids and substantial craving. He's on board with trying it as a primary opioid to see if it reduces his overall need for ED and hospital rescue treatments. And we're going to not go into this case in detail. I think we can cover this as a separate topic as we're reaching really the end of the hour. This again just highlighted the multiple different uses of ketamine, the complex pharmacology. It is an interesting agent, and also focused on the emerging or re-emerging interest in psychedelics in different areas of medicine. I want to end with not a poem this time, but an excerpt from Car Crash While Hitchhiking. I thought this was appropriate given the theme of psychedelics. And this is taken from a short story, Car Crash While Hitchhiking, from Jesus' Son by the author Dennis Johnson. And it ends with, "There's nothing wrong with me. I'm surprised I let those words out, but it's always been my tendency to lie to doctors, as if good health consisted only of the ability to fool them. Some years later, one time when I was admitted to the detox at Seattle General Hospital, I took the same tack. 'Are you hearing unusual sounds or voices?' the doctor asked. 'Help us, oh God, it hurts,' the boxes of cotton screamed. 'Not exactly,' I said. 'Not exactly?' he said. 'Now what does that mean?' 'I'm not all ready to go into all that,' I said. A yellow bird fluttered close to my face and my muscles grabbed. Now I was flopping like a fish. When I squeezed shut my eyes, hot tears exploded from the sockets. When I opened them, I was on my stomach. 'How did the room get so white?' I asked. A beautiful nurse was touching my skin. 'These are vitamins,' she said, and drove the needle in. It was raining. Gigantic ferns leaned over us. The forest drifted down a hill. I could hear a creek rushing down among rocks. And you ridiculous people, you expect me to help you." And we will end, that's the ending of that story. It's a very interesting story about the car crash while hitchhiking, and he's referring to his experience on the road. So I don't think we have time for questions. Mark your calendars for the next Addiction Toxicology Case Conference, December 4th, and then the following January 8th. On December 4th, we'll be covering drug testing during COVID-19, as well as emergency department initiation of buprenorphine, and some updates in particular related to impact of COVID-19. And watch for summary statements and the recordings to be posted on the ACMT and the ACM website. I want to thank our panelists for attending, Dr. Swager, Dr. Nelson, Dr. Eisner, Dr. Newman, and Dr. Bishevitz, and thank you all